Hello and welcome everyone to today's first ever virtual thalassemia grand rounds. This grand round is a partnership between the Division of Blood Disorders at the Centers for Disease Control and Prevention, also known as the CDC, and the Cooley's Anemia Foundation, CAF. I'm Dr. Rahul Agarwal, and I serve as Assistant Professor of Medicine, Endocrinology, and Bone Disease at the Icahn School of Medicine at Mount Sinai Hospital in New York City. I'm delighted to be with you to moderate today's virtual thalassemia grand rounds. Our topic is evaluating and managing bone health in thalassemia patients. So before I introduce our guest presenter, I'd like to go over a few helpful tips for participating in this grand rounds. Upon joining, you will see two audio options. You can opt to listen via the speakers on your laptop or by using your phone to call in. If you choose the phone option, the GoToWebinar toolbar will provide you with the phone number, access number, and audio PIN number that you will need. All participants' audio will remain muted throughout the presentation. At the end of the presentation, there will be time for questions. To submit a written question, please use the questions area of the toolbar. We will respond to as many questions as time allows. Today's rounds will last approximately 1 hour. Please note that these rounds will be recorded and made available on the CDC and CAF websites for future access. So we'll begin today's grand rounds with two brief audience poll questions that will help us better understand our audience. The first question for healthcare providers is, approximately how many thalassemia patients are managed per year in your practice? 0 to 5, 6 to 10, 11 to 20, 21 to 50, or more than 50? Please select your response to the first poll question now. So it looks like we have a wide distribution from 0 to 5 and more than 50 being the predominant numbers. We'll now proceed to the second poll question, which is approximately what percentage of your thalassemia patient population currently presents with low bone mass? 0 to 20%, 21 to 40%, 41 to 60%, 61 to 80, or 81 to 100%? Please select your responses now. Okay, great. So it seems like for most of the audience today, about 0 to 20% have low bone mass. We will now proceed to the pre-meeting assessment questions. We will ask you 3 brief questions before the meeting begins to assess your initial knowledge of the topics. These questions are directed at practicing healthcare providers. We will return to these questions again at the conclusion of Dr. Al-Muqaddam's presentation and share the responses at that time. The first pre-meeting assessment question will appear now. The question is, when would you order a DEXA scan in a young thalassemia patient? Order a DEXA only if they have a history of fracture at the age of 10 to 12 years, or order a DEXA only if they have hypogonadism. Please select your responses now. We will now proceed to the second pre-meeting assessment question, which is, what are the indications for treatment with bisphosphonates? A z-score less than -2.0, a history of compression fracture in the spine, or a t-score less than -2.0. Please select your response now. Thank you. We will now proceed to the third and final pre-meeting assessment question. The third question is, what is the first line of therapy for a young thalassemia patient with a screening DEXA showing the lowest z-score of -2.2? Non-pharmacologic therapy, denosumab, or zoledronic acid? Please select your response now. Okay, great. Thank you for your responses. We'll come back to these later in the presentation. Now, I'd like to, before I introduce our speaker, I'd like to begin with a case study to highlight some of the topics that we're going to discuss today. So the case presentation is as follows. A 32-year-old Italian woman with thalassemia major, history of splenectomy, and transfusion dependence since age 3. Most recently, she has been receiving 2 units of packed red blood cells every 4 weeks. She takes deferasirox 1,440 milligrams per day for iron chelation. She has had no prior fractures, kidney stones, or extramedullary hematopoiesis. She had normal menses from age 12 to 16 and then developed secondary amenorrhea. She does not have any other endocrinopathies. Her last BMI is 24.5, and her pertinent medications are calcium 600, vitamin D, D3 800 units per day, sertraline 25 milligrams, and an oral contraceptive tablet. Last serum hemoglobin was 8.8 grams per deciliter, and her serum ferritin was 480 micrograms per liter. Her last ferrous scan and her cardiac T2 were within normal limits. Metabolic bone labs showed a normal calcium, albumin, and phosphate, a parathyroid hormone level of 36, which is normal, and a vitamin D level of 14. Her last DEXA revealed a bone density of 0.745 with a -2.8 z-score at the lumbar spine. At the femoral neck, BMD was 0.774 with a z-score of -2.3, and her total head BMD was 0.69 with a z-score of -3.0. So some of the things we're going to talk about in the meeting today, just briefly, are going to be what would you, and these are questions we're going to come back to after the presentation, would you perform any additional diagnostics to evaluate this patient's low bone density? How often would you perform DEXA scans or any other screenings on this patient? And what is the optimal management strategy for this patient? So now it's my pleasure to introduce today's presenter, Dr. Mona Al-Muqaddam, who is an assistant professor of medicine in the Division of Endocrinology, Diabetes, and Bone Disease, with a joint appointment in the Department of Orthopedic Surgery at the University of Pennsylvania. She is the director of the Penn Bone Center. Her research expertise is in the area of a rare disorder known as fibrodysplasia ossificans progressiva, or FOP. Clinically, she sees a wide variety of endocrinology patients with a special interest in bone diseases. She's actively involved in teaching fellows and directs the weekly bone clinic for first-year fellows. And she has been personally a fantastic mentor to me and has really inspired me to make osteoporosis management an area of interest in my clinical career. So Dr. Al-Muqaddam, welcome, and let's begin.
Thank you, Dr. Agarwal, for this kind introduction. So the title of my presentation today is Evaluating and Managing Bone Health in Thalassemia. The objectives for this talk, we're going to review what is the definition of low bone mineral density. I'll go over what we know regarding prevalence of low bone mineral density and fractures in thalassemia patients. We'll identify some of the risk factors that contribute to low bone mineral density and go over impacts of iron chelation therapy on bone health. I will go over some guidelines for screening and management of low bone mineral density, and I'll probably be providing also some of my personal opinions when it comes to that. So the first thing is we really need to understand what is the definition of low bone mineral density. Right now, the gold standard is to really use a DEXA scan. Not because DEXA scans are perfect, but they're cheap, they're widely available, and are good at predicting fractures. What they measure is the areal bone mineral density. So they're not measuring volumetric bone mineral density, and they cannot differentiate trabecular bone from cortical bone. I also wanted to review two terminologies, T-score and a Z-score, and to try to highlight the difference between those two terms. The T-score is the number of standard deviations the bone mineral density is away from a reference group. And that reference group is the average bone mineral density of about a 30-year-old white female. And so the reference group is the same. And the T-score is what we use to define osteoporosis in postmenopausal women and men 50 years or above. And a T-score of minus 2.5 or below is defined as osteoporosis. We do not use T-score in younger patients. So we don't use that in premenopausal women and men below the age of 50. What we use is Z-score. And the Z-score is the number of standard deviations the bone mineral density is away from a reference group that is of matched age and sex. And we don't use Z-score solely to define if someone has osteoporosis or not. So if someone has a Z-score of minus 2 or below, we say that they are below what is expected for their age. You need presence of fractures to define someone as having osteoporosis in the younger age patients. So what do we know about thalassemia? So this is one of the earlier studies that was published in 2009 in JBMR, looking at over 300 thalassemia patients ages 6 and above. And a couple of things that I wanted to highlight. So about 50% of patients had low bone mineral density. If you look at this figure, so the column that is in dark gray, those are the patients that had a Z-score less than minus 2. And you can see that about 50% of these patients had a low bone mineral density. It seems that patients who have beta thalassemia had higher prevalence of low bone mineral density compared to the alpha thalassemia patients. The other thing to note is that the Z-score in the spine tended to be lower than the Z-score in the femoral neck. The other thing that I wanted to note is that although the prevalence of low bone mineral density increases with age, you can see that there's a rapid decline in the Z-score between the ages of 11 to 19. So the peak decline really seems to be around the age of 20, and then there's a slower decline in the Z-score afterwards. And those changes correlated with increased risk of fractures. So in the overall cohort of these patients, about 30% had prevalent fractures. And the risk of fracture seemed to increase with age. So similarly, patients with beta thalassemia seem to have lower z-scores compared to patients who had milder forms of thalassemia. And you can see in this group of patients who are ages 20 and above, the prevalence of fractures was about 70%. I wanted to review some data from our group. So Dr. Farzana Sayani leads our Penn Adult Comprehensive Thalassemia Center. And about 2 years ago, we looked back at our patient population who are transfusion dependent. So these are all patients who are transfusion dependent, and they are all adult patients. And so about 38 adults were included in this cohort, and the age range is about 18 to 63 with an average age of 37. And in our cohort, 70% of our patients had low bone mineral density as defined by a z-score of -2 or below. And 33% of them had fractures, so very comparable to other published data. What we did note was about 18% of our patients had kidney stones. And if you look at the US population, about 9% of the US population has kidney stones. So it seems that the prevalence of kidney stones is twofold higher than the general US population. In a subset of patients, really probably these are all the patients that were referred to me, who underwent 24-hour urine collection, we noted that 92% of them had hypercalciuria. And we defined hypercalciuria as a 24-hour urine calcium more than 4 milligrams per kilogram per day. And in those who did have hypercalciuria, 42% of them had kidney stones. And all those patients were on defereserox. In terms of endocrinopathy, the most commonly noted endocrinopathy was hypogonadism in 67% of patients. 44% had delayed puberty, 18% had hypothyroidism, 18% had diabetes, and 15% had history of growth hormone therapy. So what are the factors that contribute to low bone mineral density? As you can imagine, it's multifactorial, and there's a lot of reasons why our patients have low bone mineral density. But it's very important to highlight the importance of anemia and the increase in the bone marrow activity as one of the major causes for low bone mineral density. And a lot of studies have demonstrated, correlation between low hemoglobins and low bone mineral density, highlighting the importance of regular blood transfusions. Iron overload in both patients who are regularly transfused and those who are not regularly transfused can cause direct toxic effects on the osteoblasts and inhibit bone formation. Iron can also have indirect effects on bone quality by causing endocrinopathies, by causing liver cirrhosis, and by causing kidney damage. A lot of our patients have nutritional deficiencies. About 43% were noted to have a 25-hydroxyvitamin D levels less than 20 nanograms per deciliter. Patients also have zinc and other micronutrient deficiencies. In addition, what I have noted in our patient cohorts and as well as other published data that patients with thalassemia seem to have hypercalciuria and an increased risk of kidney stones. And those changes are associated with lower bone mineral density and increased risk of fractures. Patients also have decreased physical activity, which is also a known risk factor for low bone mineral density and fractures. So what about iron chelation, right? Is that another contributing factor? Well, the data is very conflicting. As you know, or as you review the data, a lot of the studies are small. They're mainly retrospective studies. And so there's a lot of confounding factors that it's very hard to determine if the reason why someone has low bone mineral density is due to iron chelation or due to the other comorbidities. But I will review some of the information that is available. So looking at defereserox, there was earlier studies that noted that there was an increased rate of decline in BMD when patients were switched from deferoxamine to defereserox. But if you review that data more closely, patients were on average between the ages of 11 to 19 when they did the switch in their iron chelating agent. And if you remember from my earlier slides, the most rapid decline in z-score really seems to happen around the age of 11 to 19. So is this increased rate and decline in BMD around this time just a coincidence? And the patients were going to have a rapid decline around that time anyway, and it was not due to the switch in their iron chelating agent. Other studies showed an opposite effect, where iron chelation with deferasirox seemed to cause less endocrinopathy and decrease the prevalence of osteoporosis versus other chelating regimens. But what we do know and what we do recognize is that deferasirox does have negative effects on the kidney, and it can cause proximal renal tubular dysfunction. It can cause Fanconi-like syndrome, and there's been case reports of patients developing osteomalacia due to phosphate wasting. What has also been noted in the literature is there seems to be higher prevalence of hypercalciuria in patients who are taking deferasirox, and also that there's a dose-dependent response where patients on higher doses seem to have higher prevalence of hypercalciuria. Regarding deferoxamine, we know that it can increase risk of long bone dysplasia, and that can affect the height of patients. So we need to be careful in the younger patient population. But what is important to note is that iron chelation has truly improved the survival in thalassemia patients. So if you look at this figure from 2000 that was published in the Lancet, and you look at the survival of thalassemia patients after the age of 12, before 1955, their survival was very low. But after the introduction of regular blood transfusion in the 1960s, and then iron chelation in the 1970s, their overall survival really improved tremendously. So overall, I feel that iron chelation is very important and is very helpful for patients. I do not recommend that iron chelation be switched on the sole reason because of low bone mineral density. So now that we have a very good appreciation that low bone mineral density is very prevalent in our thalassemia patients, what should we do? Well, we should screen them for low bone mineral density. And again, the gold standard remains to be a DEXA scan, and we recommend screening at the age between 10 to 12 years. Trabecular bone score is a relatively new software that uses DEXA-derived spine images to tell us more about the quality of the bone or the bone microarchitecture. So DEXA scan looks at the bone density. The trabecular bone score looks at the distribution of this bone density to tell us if this structure is strong or not strong. Currently, trabecular bone score is not intended for diagnosis of osteoporosis or for monitoring of pharmacological treatment. TBS, it can be used to adjust the probability of fracture in postmenopausal women and older men. In this cross-sectional study of 86 thalassemia patients, they evaluated the utility of bone mineral density and trabecular bone score. In this cohort, they all underwent lateral x-rays of their spine, and the prevalence of compression fractures was about 16% in the overall cohort. And you can tell in this figure that patients who had low bone mineral density and a low trabecular bone score had a much higher odds ratio of having vertebral compression fractures. And it also seems to show that in this figure that having an abnormal trabecular bone score might be better a predictor of fractures than an abnormal bone mineral density. Now, as far as I'm aware, I have not seen any prospective studies using trabecular bone score in predicting incident fractures. So we still don't know how trabecular bone score can be used in terms of determining who requires therapy and who does not require therapy. But it is something worthwhile looking at to determine if someone has compromised bone quality. In terms of management of low bone mineral density, I really want to highlight the importance of screening and prevention. And so managing the anemia by adequate transfusion to stop the increase in bone marrow activity is extremely important. And maintaining good iron chelation therapy to prevent iron overload and hormonal deficiency is very important. If someone develops hormonal deficiencies, please do treat the underlying hormonal deficiency. So in men, replace their testosterone, and women replace their estrogen if they have hypogonadism. Adequate nutrition is extremely important, and highlighting the importance of calcium intake and vitamin D intake. Calcium intake, there's slight differences in requirements based on age, but on average, they should be getting about 1,000 milligrams of calcium a day, and vitamin D on average about 400 to 800 units daily. However, from my experience, a lot of patients require higher doses of vitamin D. Exercise and fall prevention is extremely important, and it's really important to also counsel them on avoiding things that could further negatively affect their bone quality. So you have a person with low bone mineral density. Should you treat with pharmacological therapy, yes or no? And really, there are no guidelines for younger patients. But what we do all agree is if someone does have a history of a fracture and they have a low Z-score, those patients should be treated. And so that's an easy answer. But if someone does not have a fracture, I would favor more conservative management of really optimizing their lifestyle, their nutrition, treating any other underlying comorbidities, and repeating a bone mineral density once a year. And consider treatment if they have a significant decline in their bone mineral density, or if they have a really low Z-score of about -1.5 or -4. So if you do decide you want to go through the pharmacological therapy route, what are the potential options? So this goes over all the approved drugs that we have in the United States for treatment of postmenopausal women with osteoporosis. None of them are specifically approved for thalassemia-associated osteoporosis. When we think of osteoporosis, and even also in our thalassemia patients, there's an imbalance between the amount of bone being removed compared to the amount of bone being formed. So patients have high bone resorption by the osteoclasts. So we have medications that work as anti-resorptive agents, and then we have medications that work by stimulating bone formation, and we think of those as osteoanabolic agents. I will briefly go over bisphosphonates and denosumab because these are the only two agents that have been studied in thalassemia patients, and they're both anti-resorptive agents. So in terms of bisphosphonates, the reason why I put in this table is to highlight a couple of things. Most of the studies with the use of bisphosphonates are 1 to 2 year studies. So those are short-term studies. And none of those studies really looked at fracture outcomes and to see if those interventions decrease the risk of fractures. What they do look at is changes in bone mineral density. And across the board, treatment with bisphosphonates is associated with improvement in bone mineral density. I wanted to highlight another thing. The most widely used bisphosphonate is IV zoledronic acid. And I wanted to highlight that what we use in terms of dosing is 5 milligrams every 12 months for treatment of osteoporosis. And the doses that were used in thalassemia patients were 4 milligrams every 3 months or 4 milligrams every 6 months. So the doses are slightly different. With denosumab, this is also a 1-year study on 63 thalassemia patients that were randomized to either receive denosumab or placebo. And after 1 year of treatment, they had a significant improvement in their bone mineral density. And the patients who received denosumab had 6% improvement in their lumbar spine versus 3% in the placebo arm. And that reached statistical significance. Again, fracture data is not available. So, but we have to weigh this with the long-term side effects of these medications. So as I mentioned, the studies that were done in thalassemia were short studies, were 1 year, 2 year studies. And so what happens to patients after 5 years or 6 years? What we do know is these medications are associated with long-term side effects. So with bisphosphonates and also with denosumab, they can have atypical femur fractures. Usually those occur after 5 years of therapy with bisphosphonates. And what atypical femur fractures are is basically a stress fracture that can happen in the thigh bone. And so it presents initially, patients present with dull, aching, nagging pain. And if you do an X-ray, you would see some lateral cortical changes. And then several weeks later, they can have a spontaneous fracture in their femoral shaft. The other one is osteonecrosis of the jaw, which is also an extremely rare side effect, but can happen in patients who've been receiving long-term bisphosphonate therapy and are also receiving higher doses of IV bisphosphonates. And basically what that is that the jawbone is exposed and is necrotic, and this doesn't heal for over 8 weeks. Some patients will require extensive surgical debridement to treat this condition. These side effects, they are rare, but they are associated with significant morbidity. Denosumab, one thing I wanted to mention about denosumab is that it's a very reversible medication. And there is concern for rebound bone loss and multiple compression fractures if denosumab is abruptly stopped. And so from my perspective, I don't like to use denosumab as a first-line therapy, especially in our younger thalassemia patients, where we don't know in terms of duration of therapy for how long to continue those patients on denosumab. So now that you recognize all these side effects, you're like, okay, is there something else that we can do for our patients that doesn't have side effects and they can use it long term? And at least from my own patients, I know they're really interested in non-pharmacological therapy. And so how about low magnitude whole body vibration? The theory behind that is that we know that in animal models, low magnitude vibration stimulates mesenchymal cells towards the osteoblast production and decreases the production of adipocytes. And so at least in the animal models, putting them on a vibrating platform seemed to increase their bone mineral density. In human studies, it's been very hard to demonstrate that. The problem with the human clinical trials is that the compliance is very poor, and either a lot of patients drop out from the study or they don't stand on the platform as they're supposed to. Also, different studies have used different magnitude and frequency of vibration, and the duration of standing off this platform is very variable, for anywhere from 10 to 20 minutes or even higher per day. And in terms of the results, the outcome has really looking at changes in bone mineral density or other parameters of bone quality, but none of them looked at fracture risk reduction. And most of them showed minimal but non-consistent improvement in parameters of bone quality. There was a small pilot study in thalassemia patients where it was a 12-month crossover study in 18 thalassemia patients, 9 of which were adults and 9 of them were pediatric patients. And the intervention was that the 9 adults in the first 6 months were getting the intervention, and then after 6 months they were not, they were on placebo, or they were not getting the platform. And then the pediatric patients were got the platform from 6 to 12 months. They were expected to stand on this platform for 20 minutes a day, 6 times a week. The adherence for both groups was not great, but it was better in the first 3 months compared to the second 3 months. And as you can see, that the compliance in the second 3 months was about 50%. And in that small pilot group, the adult group had a significant improvement in their areal bone mineral density of 1.3% at 6 months. So potential side effects, one patient dropped out of the study because of back pain and another patient dropped out of the study because of dizziness. Since this is not a placebo arm and not a randomized trial, we can't really tell if the back pain and the dizziness was really due to this platform. For my patients, when they ask me about this device, I say, the side effects are very minimal. If they are able to afford it, go ahead, they can buy it. Sorry. I do want them to be very careful not to fall. There are several devices available to buy online. This is not reimbursed by insurance companies, so they would have to pay for it. I don't know what is the recommended amount of time that they should be standing on this platform. So in conclusion, low bone mineral density and fractures are very common in thalassemia patients. Transfusion and iron chelation have significantly improved mortality and morbidity, increasing the importance of screening and treatment of low bone mineral density. Lifestyle and nutritional changes are recommended for all and are considered first-line therapy in younger patients. Screen and address comorbidities that could be contributing to low bone mineral density. My personal recommendation is all patients should get a 24-hour urine collection for calcium to screen for hypercalciuria. Pharmacological therapy should be reserved to patients with fractures or whom you believe are at very high risk of having fractures. And bisphosphonates are the most widely used pharmacological therapy. So with that, that concludes my presentation. I'm going to hand it over to Dr. Agarwal. Thank you.
Hi, thank you so much, Dr. Al-Muqaddam, for that truly educational presentation. I'm going to quickly return back to the case discussion. And, just as a brief case summary, we had a 32-year-old woman with transfusion-dependent beta thalassemia, major complicated by secondary amenorrhea on an oral contraceptive, vitamin D deficiency, and low BMD for age with the lowest Z-score of -3.0 at the total hip, but no prior history of fractures. So for a patient like this, what additional diagnostics would you perform to evaluate her low bone mineral density?
So I think for this case, a couple of things to highlight. Like you correctly mentioned, the patient has a low Z-score, so I would say that she has her bone mineral density is below what is expected for her age. Luckily, she's never had a fracture, so I wouldn't be labeling her as osteoporotic. In terms of what additional diagnostic evaluation, screening for other endocrinopathies is recommended, and we do recommend that, and that should be done once a year. So I would recommend that. Definitely checking her liver enzymes and her kidney function is also very important. And of course, 24-hour urine collection for creatinine and calcium. So that's always going to be something that I do screen and check for all of my patients. And I'm just going over the other questions that you had for me. How often would you perform a DEXA scan or any other screening on this patient? So I think we're in the sense for this patient, yes, she does have a low Z-score, but there are things that we can modify for her as well. So her vitamin D was pretty low, and replacement of her vitamin D would be adequate, and I would recommend repeating that vitamin D after she's been replaced. But then I would do an annual DEXA to see how her DEXA changes with time, and do that on an annual basis. And so going to the third question, which is what is the optimal management? Again, that would be really kind of focusing more on the lifestyle modification and nutritional advice, where she should be getting adequate calcium intake and adequate vitamin D intake, encouraging exercise, weight-bearing exercises, and reporting to me if she has a fracture, because having a fracture is the thing that would make me change my recommendation. And so I always tell my patients, I want to see you back next year, but please call me earlier if you have a fracture, if you break a bone.
Great. Thank you so much. I see a lot of questions coming in from the audience, but before I get to those questions, we're going to quickly go back to the pre-meeting questions and review those responses. So I will go back to that first pre-meeting assessment question, and we'll do the poll again. So the first question was, when would you order a DEXA scan in a young thalassemia patient? Order a DEXA only if they have a history of fracture at the age of 10 to 12 years, or order a DEXA only if they have hypogonadism. Please select your response. Just waiting on the polling to show the results. And it looks like, most of you selected at the age of 10 to 12 years, and that is the optimal time for that first screening, as Dr. Al-Mukarram stated. So that's the earliest time we start seeing a decline. We can proceed to the second post-meeting assessment question. This question is, what are the indications for treatment with bisphosphonates? A z-score less than -2.0, history of a compression fracture in the spine, or a t-score less than -2.0. Please select your response. And most of you selected a history of a compression fracture. And here, it's very important that we rely on clinical fractures when the bone density is only mildly low. So the best response is the history of a compression fracture. Now we can proceed to the final post-meeting question. And the third and final question was, what is the first-line therapy for a young thalassemia patient with screening DEXA showing the lowest z-score of -2.2? Non-pharmacologic therapy, Denosumab, or zoledronic acid? Great, and it looks like most of you selected non-pharmacologic therapy, and I think focusing on lifestyle, as mentioned in the presentation, is the key for this mild low bone mineral density. So with that, I'm going to proceed to the questions that are coming in our webinar. So one of the questions, that seems to be highlighted here is the prevalence of hypercalciuria and kidney stones. So do you do any other screening for kidney stones specifically, other than a 24-hour urine?
Yeah, I was going through the questions, so I might lump that along with the calcium and vitamin D supplementation, because I saw a lot of questions about that. So in terms of the 24-hour urine collection for calcium and creatinine, as soon as patients are coming to me, I do the 24-hour urine collection. So I see adult patients, so they're coming to me above the age of 18. In terms of the timing of doing it, I think once you feel like your patient can comply to that, right? So I don't know, a 10-year-old maybe will not be able to collect urine over 24 hours, but as soon as you feel like your patients are able to comply to 24-hour urine collection, I would say go ahead and do it. In terms of how often to do the 24-hour urine collection, it depends on what the baseline results look like. But if they're hypercalciuric, definitely once a year. If they're not, maybe you can space it out a bit more. We don't have a lot of that information to give you clear recommendations on how often that should be checked. In terms of checking for kidney stones, I don't know if we necessarily need to do any additional imaging on those patients to look for kidney stones. Unless they have significant hypercalciuria, I wouldn't recommend any additional imaging. I feel a lot of our patients are getting imaging looking at liver iron scores, and they're having other imaging done, and you can easily screen those imaging to see if there's any mention of renal calculi on those imaging. But unless patients are symptomatic and they have very high urine calciums, I personally do not do a routine screening for kidney stones. And I think the one question was also regarding calcium and vitamin D supplementation, which is an excellent question. And because of the time, I didn't go over a lot of details. But what we talk about is calcium intake in terms of adequate calcium intake. And I didn't mean that it has to be supplementation. I actually recommend that all my patients get their calcium from diet and not from supplements. And adequate calcium intake of 800 to 1,000 milligrams a day should not increase the risk of kidney stones. And so there's actually studies that show that patients who restrict their calcium intake or are on a very low calcium diet actually have increased risk of kidney stones. And part of that is because calcium acts as an oxalate binder in the GI system. And so if someone's having a very low calcium diet, then they can increase the risk of having high oxalate in the urine and then increase the risk of actually having kidney stones. So my recommendation is adequate calcium intake, but not supplementation. It should be through their diet. And in terms of what is an ideal vitamin D level, that is again a very controversial topic. The Institute of Medicine, they recommend a 25 hydroxyvitamin D above 20 at least. And as an endocrinologist and in people who have low bone mineral density, and especially if you're considering pharmacological therapy for low bone mineral density, I would aim for a 25 hydroxyvitamin D above 30. And that's also to decrease the risk of hypocalcemia when you're giving patients bisphosphonates or denosumab.
Great, thank you. There's a couple of questions I see here about treatment duration, and also a question regarding a bisphosphonate holiday at 5 years, which is considered in our adult osteoporosis patients. What are your thoughts on that?
Yeah, so excellent question. So what I do, again, I try to be conservative because of that reason, is because there's a timestamp for how long you can use bisphosphonates. And that's really why I try to do much more conservative measures initially. But in people who've had fractures, you have to treat them. And what I usually do is I do IV zoledronic acid 5 milligrams every 12 months. And I do that for 3 to 6 doses maximum. And then after 3 to 6 doses, I assess where they are right now. I assess their bone mineral density. I assess their fracture history. If I feel that they're still at very high risk of having fractures, or meaning that they've actually had several fractures while on therapy, then I try to use other treatment modalities, and I try to use medications that stimulate bone formation. Although those were not studied in thalassemia patients directly, I do sometimes use them in very, very high risk patient population. And they have their own kind of side effects, but we do have other treatment options if they are actively fracturing. But usually giving zoledronic acid for 3 to 6 years does the job, and their bone densities improve, and hopefully they won't have any fractures. And what I do is then I monitor them and give them a drug holiday and repeating their DEXAs annually. And if I notice that their bone density is again significantly declining, and I check bone markers and see if their bone markers are going back up again or if they're still suppressed. And after a drug holiday, I feel more comfortable reinitiating bisphosphonates.
One of the questions, I don't see it here yet, but just a question I had. If the patient is a male patient, is your management or diagnostics anything you do differently?
Yeah, so that's an excellent question. So because when I talked about treatment options, most of the studies were done really in postmenopausal women, right? And so some of the osteoporosis agents that we have are also approved in men, but really most of the studies have been in postmenopausal women. But for our thalassemia patients, actually being a man is actually a risk factor for having low bone mineral density. So all of the studies shows that men are more likely to have low bone mineral density than women. So this is definitely something that needs to be addressed in men, and that they need to be treated. In terms of what treatment options, I would continue to do the same thing in that sense, in terms of it would be bisphosphonates as well, but definitely treating any underlying hypogonadism or other contributing factors need to be addressed as well.
Great. So 2 questions I see here regarding diagnostics. One question regarding using volumetric CT assessment of bone density, and another wondering about using TBS and vertebral fracture assessment in pediatrics where it is not fully validated.
Yeah. So, all right, so let me go over the first question. So the first question was about the utility of volumetric bone mineral density. So I think we all have an understanding of limitations of DEXA scans and aerial bone mineral density, and how other artifacts and compression fractures can really affect the results of aerial bone mineral density. So in that sense, the volumetric bone mineral density can overcome some of the limitations by DEXA. The problem with volumetric bone mineral density is that it's not very widely available, and not a lot of centers have volumetric bone mineral density. It is important to use the same modality on follow-up to see if there's any changes in the bone mineral density, and there's less standardization of different cutoffs compared to DEXA scans, just because DEXA scans have been around longer and we have more of kind of reference data. But I definitely think that volumetric bone mineral density is the way to go, and it will provide you more detailed information and can provide you more information about the trabecular bone and the cortical bone. And so if you have that option, I would recommend doing that.
And the other question was regarding TBS and VFA in pediatric patients, about validity of that.
Yeah. So again, the trabecular bone score is still relatively new, and I personally don't know how trabecular bone score changes with growing bones and with age and with puberty, and as I mentioned, there's a lot that we still don't know about trabecular bone score. So we have to really see what the prospective studies look like. In terms of VFA, so basically what a VFA is, just for people who don't know, it's basically utilizing a DEXA scan to do lateral x-rays of the spine. So it's like a low resolution x-ray of the spine to look for compression fractures. If you are in a center that is very experienced at doing those lateral VFAs and your technicians are highly invested in reviewing the images and correcting any misplacement of the points of the vertebra, then yes, you can do the VFA to look for compression fractures in your patients. My concern with the VFA is a lot of it is automated, and it's incorrectly automated, and if no one's really paying attention to those results, a lot of erroneous results will come out of it.
Sticking with the diagnostics, I guess another interesting question about adjusting for height for bone density DEXAs, and that's done in children. Would that be something done for adults with lower height?
Yeah. Again, these are very, very good questions and very complicated to answer, because these are a lot of things that introduce to some of the limitations of DEXA scans. And so at least in our group at CHOP with the Bebet-Zemel, they do height adjusted BMDs. They do adjust for the height, but in terms of in adults, in patients who are very short, we do sometimes do apparent bone mineral density. And so we do try to adjust for patients who are smaller because of the fact that you're doing aerial bone mineral density. What ends up happening is patients who are shorter, especially less than 5 feet, then their aerial bone mineral density would be underestimated, would be much lower than their volumetric bone mineral density. So to overcome for that, there are some calculators that can be used to adjust for that.
Okay, great. Shifting gears a little bit on lifestyle, question related to that. Fear of exercising and potentially causing a fracture. Is there like specific recommendations you give your patients on what are safe exercises?
Sure. So it's always a challenge, right? So you have a huge spectrum, so it's very hard to give one kind of recommendation for all patients, because it really depends on how low their bone density is and if they've had compression fractures in their spine or not. I would hate to limit the activity of a 20-year-old patient who has a Z-score of -2.3. I would say just let them be active, do the sports that they enjoy doing. But then if I have a patient who has a Z-score of -4 and has had multiple compression fractures, then that patient, I might tell them, you know what, let's do the low impact exercises, don't do the high impact exercises. You don't want to lift anything heavy that's more than 10 pounds. You don't want to over rotate your spine. You don't want to over bend your spine. So what is recommended is, impact exercises, and weight-bearing exercises, resistance exercises, and core strengthening exercises. So those are exercises that are very important for osteoporosis to help build bone, but also prevent injury from happening. But I really want people to enjoy the exercise that they're doing, and I try not to over-restrict their activities in that sense.
And a couple questions regarding iron chelation and hypercalciuria. I know you mentioned that with a couple of the agents. Is there a known direct correlation or mechanism for why that might happen? I know you mentioned about not necessarily switching iron chelation, but do we confirm no, that hypercalciuria is associated?
Yeah, well, I mean, okay, so in our patient population, kind of a disclosure, right? All of our patients were on defereserox, but honestly, majority of our patients were on it anyway, because it's more tolerated, it's an oral drug, and so it's hard to tell if it's really due to the drug or not, or is it just now we're checking 24-hour urine collections and they all happen to be on the same iron chelating agent. And that's where I feel doing 24-hour urine collection on all patients at baseline and really having a better understanding of the risk of hypercalciuria is going to be important. And in terms of the pathogenesis of that, how that happens, I don't think that's very clear, but part of it is that part of the proximal tubular dysfunction that happens that causes this calcium leak. So I personally think it's a very interesting topic to be further investigated. Unfortunately, if you look at all the studies that looked into that, they define hypercalciuria so differently in different studies. And some of the studies were based on spot urine, not 24-hour urine collections, and they used different cutoffs in different studies. So to understand the actual prevalence of hypercalciuria, it would be nice to do it more systematically and using similar definitions across the board.
We're almost coming up to the top of the hour, so I'll ask a couple more questions. One useful question about using hydrochlorothiazide for hypercalciuria in these patients to further allow them to take the right amount of calcium and vitamin D. What are your suggestions for that?
Yeah. So hydrochlorothiazide is a diuretic which helps to reabsorb calcium from the urine. And it has been shown in at least osteoporotic patients who have idiopathic hypercalciuria that hydrochlorothiazide can decrease risk of kidney stones and also help improve bone mineral density with or without use of bisphosphonates. As far as I'm aware, and the last time I've looked, I haven't seen any studies specifically in thalassemia patients on the use of hydrochlorothiazide. I personally have used it in my thalassemia patients who have significant hypercalciuria and have history of kidney stones. But I cannot tell if it really improves their bone mineral density or not. But the hope that it would, if we're extrapolating other patient populations where hydrochlorothiazide had been helpful for their bone mineral density.
Great. I guess I'll just do one or two last questions. Do you ever worry about a vitamin D level being too high? More than 50 or 60 with increased risk for kidney stones. And on that same line, do you have a favorite vitamin D supplementation regimen, or is it really dictated by the blood level?
Yeah. So, okay, very good questions. Yes, I do worry about vitamin D toxicity, especially now with COVID-19. I feel a lot of my patients are over supplementing with vitamin D, and I'm seeing, much higher levels right now than I ever did. And you could get vitamin D toxicity. And of course, in our patients who've had kidney stones, you don't want their vitamin D to be too high. And so I usually aim for a 25 hydroxy vitamin D level between 30 to 50. And in terms of supplementation, I usually recommend vitamin D3 in terms of a supplementation. And in the past, I used to recommend all patients take 2,000 units a day because I felt 2,000 units a day would replace everyone and almost no one would be toxic. Now maybe I do more 1,000 units a day and see what their levels look like.
Okay, great. Any final words of advice for the audience before we conclude?
Yeah. No, thank you. I think these patients are, dealing with a lot, and their bone density is kind of the least of their concerns, because someone having a low bone density will not have any symptoms, so they're not complaining about this. It's not causing the pain. But it is important, because when they do have a fracture, that's associated with significant morbidity and mortality. And so although these patients are having to go to the doctor a lot and are doing, recurrent blood transfusions, I think whatever we can do to streamline the process for them to make sure that they're getting their adequate screening and counseling is very important. I think Dr. Sayani and myself have a very nice working relationship, and she actually orders a lot of the studies that I need with their other blood tests, so that way at least they're minimizing the number of times they have to go to the lab, and that way it kind of streamlines the process so that they're not having to go to the doctor's office multiple times in addition to everything else they have to do.
So thank you so much. I just really want to thank Dr. Al-Muqaddim for providing us with such valuable information on this topic that is really so important for our patients with thalassemia. I just want to take an opportunity to thank our colleagues at the CDC's Division of Blood Disorders and the Cooley's Anemia Foundation for this invitation to be with you today and for hosting this grand rounds. If you have any additional questions about today's presentation, please contact Cynthia Sayers at sayers@cdc.gov. This grand rounds will be archived and the content will soon be available on the CDC's Division of Blood Disorders website and on the Cooley's Anemia Foundation website, as shown on this slide. And the contact information for Ms. Sayers is on here as well. And truly, thank you all of you for joining us today. And I know if there's more questions coming up, we'll try to answer them offline as well. Thank you.
Thank you.